Hi, good morning, everyone, and thank you for joining us for this webinar on collaborative care. We'd like to remind everyone to keep your lines muted for the duration of the webinar. If you have a question, please send it into the chat box, and we'll try to address those during the question and answer session at the end of the webinar. Any questions we can't get to, we will send out a frequently asked questions page addressing those questions along with the recording for those of you who registered. We'll also post this to the partner portal. We'd like to begin by acknowledging excuse me here, there we go. We'd like to begin by acknowledging with humility that the land where we are today is the territory of the people of the Salish Sea. Their presence is imbued in the waterways, shorelines, valleys, and mountains of the traditional homelands of the Coast Salish people since time immemorial. All right, I'd like to begin by introducing Sarah Barker, Assistant Director for Implementation at the University of Washington Ames Center. Sarah will be going first and then introducing Dr. Francie Chalmers from Skagit Pediatrics after her piece is over. Sarah, I'll go ahead and hand it off to you now.
All right, thank you. Good morning, everyone. For those who don't know us at the Ames Center stands for Advancing Integrated Mental Health Solutions, and we're located in the Department of Psychiatry and Behavioral Sciences at the University of Washington. My name is Sarah Barker. I've been at the Ames Center for the last 3 years. We've been heavily involved in integrated care training and workforce development in Washington State, and we have history of doing this work around the country. If you want to go to the next slide, Lindsay. Maybe, I think you. So some of the things, and you can click one more time too. So this just shows, the purple shows, I think, all the states that we've worked in. I think we've trained, what did they say, over 1,000 different practices around the country around integrated care. We're most well known for our work around collaborative care. Back one slide. Specifically in Washington State, we've done a lot of work recently at a policy level, one being on the committee for the BRIE collaboratives recommendations for behavioral health integration. We've also been heavily involved in the Medicaid transformation project, the development of the toolkit, passage of the collaborative care codes. You might know our work as well lately for training and support for the state opioid response. We're up in the North Sound region a lot with partners up there in behavioral health community and primary care partners doing training around opioid use disorder. We also are working with many of the accountable communities of health in training and technical assistance around whole person care. We have an integrated care training program that I'll tell you a little bit about a little bit later. And F2HCs have worked with us with a partnership we've had with CHPW around their mental health integration program. So hopefully our work isn't new to most of you, but if it is, I'm delighted to tell you a little bit more about it today. Go ahead to the next slide. So the journey, we've all been embarking on around whole person care. I like to start with this slide. It's really about developing, this care continuum, or in this case, it's a pyramid, thinking about how do our patients, our clients move through our systems of care. And in this work and with accountable communities of health, it's been really great to see how at a regional level, this care continuum is looking from community organizations, community-based services, to primary care, to specialty care, whether that be specialty behavioral health care, inpatient hospital settings, and how do we best support our patients and help our patients get through these complex systems that we have developed. In our work at the Ames Center, we have mostly been focused on kind of the blue and the green sections. So we're going to focus today on the blue, which is increasing access to behavioral health services and primary care, and how do you think about that as a stepped approach from the primary care provider to integrated behavioral health team members, to maybe access to psychiatric services, whether that be a psychiatric consultant or otherwise. Then how do patients who need additional levels of support get into specialty behavioral health care? And how do those partnerships form, and how do we collaborate together? We also have been in the space of working with behavioral health agencies and thinking about how to create behavioral health homes, how to increase access to primary care services for those with serious and persistent mental illness. But today I'm going to focus mostly on talking about collaborative care in the blue section of this pyramid. Go ahead to the next slide. So when we think about what approach works, and when we talk about that at the AIMS Center, we know that no one approach fits all. And I think our founding director, Dr. Jürgen Unitzer, I'm sure some of you have heard him speak before, he talks about arguing about the best integration models a bit like arguing about the best religion. We know that there's some really key evidence-based practices out there that are tried and true, have been tried and true in all the research that work. But then how do you adapt those principles, those processes, those practices, those interventions to the local setting? Maybe that's how do you adapt it to working in a rural setting or a more urban setting or different populations? We're going to hear in a few minutes from Dr. Chalmers, who's going to talk about how do you adapt this model to working with the pediatric population. Maybe it's about how do you work with co-occurring disorders and use these evidence-based practices. And so today I'm going to focus on what are those principles, what are those key takeaways as you are working to do whole person care or integrated care in your practice that are really key things to think about adapting for your setting. So keeping that in mind as I'm talking kind of for the next few minutes. Go ahead to the next slide. So there are three principles that I'm going to touch on. And these three principles, we really talk here at the AIMS Center about whether as you think about your whole person care strategy, whether that be as you think about whole person care from a primary care perspective, from a behavioral health perspective, there are three things to keep in mind. And the first one is being team-based and person-centered. So really defining the role of the primary care team and the behavioral health providers. Sometimes that might be part of a partnership. We're seeing in many places around the state, in particular, some of the ACHs we're working with, it might be that behavioral health agency partnering more closely with primary care. Maybe they're starting to staff their behavioral health team into a primary care clinic. Or maybe that primary care team is hiring now behavioral health providers, contracting with psychiatric services as part of their service line. So the first principle is team-based and then person-centered. So how do you effectively share information and do a shared care plan together? The second one I'm going to touch on is being population-based and data-driven. And when we talk about population-based, which I know is quite the buzzword right now in healthcare, it's really about how do you define a group of patients or clients and track them at a caseload level, making sure that no one falls through the cracks. So it's looking at that defined population, which we considered a caseload here at the AIMS Center, and how do you make sure that people are getting the best care that they can, that we're stepping up or down care if they need it to get patients better. The third principle that we talk about is measurement-based treatment to target. So making sure that treatment goals are clearly defined and tracked for every patient, that a team is looking at measurement-based tools, so looking at something like a PHQ. That's not just something that's done at screening, maybe at the end of sessions with patients several months later, but it's continuously used and used as a monitoring tool to think about, am I providing the best care I can to my patients? What's something else, maybe a medication recommendation that I need to think about, or new psychotherapy that needs to be tried? So measurement-based treatment to target. So how am I using these tools? How am I using measurement-based care principles? And I'll give you some examples of that as well in the next few minutes. So go ahead to the next slide. So specifically for collaborative care, when we think about who are those team members on your team with collaborative care, there's two key team members that you're adding to that primary care team and that relationship that that PCP has with the patient. So the first one is the behavioral health provider. Some of you who are familiar with collaborative care, in the literature that that role is often talked about as a behavioral health care manager. I'm going to use behavioral health provider because more and more care manager can get confused with other care manager roles that are out there. That behavioral health provider, though, that's part of that primary care team, we see that look different in all different settings. So it might be a social worker, it might be a psychologist, it might be a mental health therapist. In some places, they use nurses in this role for collaborative care and train them up on behavioral health interventions as well. So that's what I'm talking about when I talk about that behavioral health provider role. They're very engaged on part of that primary care team, doing as much as they can, those warm handoffs, or we like to say warm connections with the patient. They're rubbing elbows with the PCPs and the MAs and helping engage clients early in the process. So as soon as patients are identified, trying to get them in as quickly to see them or seeing them that day. I'll talk a little bit more about other things that behavioral health provider does. But they have that key relationship with that PCP and that patient, which is really key. That's why you see these black arrows. The psychiatric consultant, so the other role with collaborative care that we add to that primary care team is the psychiatric consultant. And this is different than other approaches to behavioral health integration that are out there. It's something that's really makes collaborative care unique, where when we talk about access to psychiatric services, it might not be that that patient always sees that psychiatric provider face-to-face. Often they don't, and most often they don't in collaborative care. So it's a consultant role. It's about spreading psychiatric services more broadly across the population, and I have a slide to illustrate that in a minute. So that psychiatric consultant role is meeting weekly. Often they're on the phone. They're not necessarily in the clinic. They might be on the phone meeting weekly, doing what we call a case review process with that behavioral health provider. So they're looking at patients on a caseload of that behavioral health provider and saying, maybe we should think about a change in this medication or a new therapeutic strategy to try, or here's some recommendations or some tips I want to give back to that PCP. In this model, the PCP is still the one who's ultimately prescribing and managing those patients, but they're getting the support from both that behavioral health provider and that psychiatric consultant. So that's why you see this dotted line, and I have some a slide in a minute to kind of illustrate that further. Go ahead to the next slide. So just a couple additional things about that behavioral health provider role. I think for many of you who are on the call today, you're probably, maybe you already have someone who's part of your team, or you're considering, should I hire, who should I hire? How is this position maybe unique from other models that are out there? So similar to other approaches to behavioral health integration, this behavioral health clinician that's part of that team, they're facilitating patient engagement. They're working on those warm handoffs. They're alongside the PCP. They do an initial assessment. They conduct follow-up visits. They often do some of that work by phone. One of the hallmarks of collaborative care is that early engagement, that first month, having several contacts with that patient is really important to engagement in collaborative care. So they're actively working by phone or in person to reach out to their patients. They're tracking those patients. So they're really looking not just at that individual patient, but they're looking at their caseload of patients and saying, who hasn't been in for a while? Or, this patient really isn't improving. Their PHQ is still at a 22, and I have been meeting with them for the last couple months. And what is something different that I can try with them? Or maybe I need to ask my psychiatric consultant for some consultation on this. The other piece that they do is they conduct this case review, the systematic case review that happens usually every week with a psychiatric consultant. So they're sitting down. Again, maybe the psychiatric consultant's remote. They might be somewhere else. I mean, we have some practices where the psychiatric consultants across the country. So it doesn't have to be someone right in the clinic, but they're looking together at the caseload and saying, what are ways we can get these patients better? And what are some changes we can make in the current treatment plan for patients who are not improving? All right, yeah, go ahead, psychiatric consultant. So the psychiatric consultant role, so I've touched on the role of the psychiatric consultant for the caseload review. So a big piece of what the psychiatric consultant does is they're looking at that caseload of patients that behavioral health provider is managing, and they're looking and saying, who's this new patient that maybe is on this caseload, and what medications have they been on, and what medications might we change? Which patients are not improving? For instance, that patient I mentioned that has a PHQ that's just been stuck, let's say at 20. Why aren't they improving? And what's something different we should do in their care? They're really providing that oversight to that caseload, and then they're offering those recommendations to the PCP about changes that maybe need to be made with that medication, or maybe to that behavioral health provider to say, hey, maybe we should try a different therapeutic approach, or connect them to some other service because they haven't been improving over the last few months. Another piece that's really important in this relationship of the psychiatric consultant to the primary care team is to have some sort of availability to consult and be engaged with the primary care providers. This looks different in different models of care. Sometimes there's the ability to be able to message a PCP to message your psychiatric consultant in the EHR. Sometimes it's coming to like a lunch and learn once a month, let's say, and meeting with PCPs to review cases. Sometimes it's, hey, having that psychiatric consultant's cell phone number and being able to call them with any kind of diagnostic questions or complex cases, et cetera. But that's another key piece of that psychiatric consultant role. Go ahead to the next slide. So I like this slide because this illustrates what we're trying to get across when we talk about leveraging access to psychiatric services. So it's really around how do you spread a psychiatric provider's time across a population of patients. And so in this instance, you have 3 care managers, and let's say a clinic has a psychiatric consultant for about 8 hours a week. They're able, by looking at a caseload of patients and taking a population approach, they're able to touch on, all of these patients. So here we have 150 or a little more than that, because they're spending their time, their 8 hours a week in this consultant role versus trying to see in those 8 hours all these patients in person, which obviously wouldn't happen. So again, this just illustrates that it's this population perspective, and that's what we're talking about when we talk about a psychiatric consultant in collaborative care. All right, next slide. All right, the second principle, when we talk about population-based care, I think the best way to illustrate this is to show you an example. It's really around tracking a caseload of patients. This isn't about the management of the entire PCP's panel. This is around the behavioral health provider's caseload and how are they actively monitoring their caseload. So again, rather than looking at each individual patient, which they have to do at times too, but they're also able to quickly see, when was their initial PHQ, what's their last, what's their GAD score, when was their last contact. In this example, this is from the AIMS Caseload Tracker. PC is a psychiatric consultant. When was the last time they consulted with their psychiatric consultant? How many weeks has this patient been in session? Do I need to think about stepping up care? Maybe they need to be referred out, or maybe it's time to kind of do what we call relapse prevention planning in collaborative care. So tracking these patients over time, looking at who's falling through the cracks, who do I actively need to engage in maybe a systematic case review, or I need to reach out to with a phone call. That's what we mean when we talk about caseload tracking and population-based care. Go ahead to the next slide. I like to compare it because I think for primary care practices, especially those that come from maybe having worked with registries and in the chronic care model, tracking your diabetes patients or your asthma patients, those with hypertension. When I did that work in primary care, we were thinking about it from looking at the whole clinic, like all the diabetes patients in that clinic, all the diabetes patients on a provider's panel, and thinking about proactively reminding them. It's a little different with collaborative care because you're not looking at just that PCP's panel, you're looking at that caseload of that behavioral health manager, care manager, or behavioral health provider, and how can you systematically review them with the psychiatric provider and think about treat to target and look at their scores and think about how can I improve their care. So I just like to compare the two. I think it's can be confusing sometimes. Go ahead to the next slide. All right, the third one, which I think this is a buzzword that we hear a lot with behavioral health integration, but it's really important piece of collaborative care is measurement-based care. So again, it involves the systematic tracking of symptom rating scales. So most often we start with the PHQ, but there are other rating scales out there as well. And we use that to drive clinical decision making. So again, it's not just collecting this and screening and using it for screening for diagnostic purposes, something like the PHQ, but you're using it for treatment to target and tracking over time to see how are my patients doing, are they getting better, and it's part of kind of the whole mix when you're reviewing cases of patients. Go ahead to the next slide. So just a couple examples from the literature, if you're not familiar with some of these studies, but one of them I think that really stands out, and it came from Mayo, and it looks at time to remission for depression. So when they define remission, they're looking at a PHQ score of less than 5. They found that, in usual care, it was 614 days, and in collaborative care, it was 86 days. And I think that really highlights that with collaborative care, we're not talking about long-term therapy. It's not a referral out that we're waiting for that patient to eventually get into behavioral health. It's about actively engaging them right away at that PCP visit, engaging them then maybe with a follow-up call, in-person visit shortly after that PCP visit. It's also doing this case review process, so getting support from the experts, from a psychiatric provider to help you review these patients and make recommendations. It's a very active form of providing care to patients because you want to get patients better and you don't want it to drag on for a long time, and you want to track who those patients are. So often maybe that patient gets referred out, we don't know what happens, they get lost for follow-up, but this is actively engaging patients in care and getting them better. And people ask us often, what's an average collaborative care episode of care? Often it's around 6 months. Sometimes it's less. It could be more like 3 to 4 months, or it could be a little bit more. It could be 7 or 8 months. But it's shorter than, a year or 2 years trying to get patients better. All right, the next slide. I wanted to highlight this study comes out of New York, and we've done a lot of work out in New York, and kind of the differences between co-location and collaborative care. I think the big thing is this reduction in PHQ-9 scores, so actively looking at, is my patient improving? And the other two main things that happen, I think, that are, again, to distinguish between other models of care, maybe just having a co-located behavioral health provider to collaborative care, is this frequent contact of that behavioral health provider with the patient, whether it be by phone or in-person visits, and then having this caseload review process where it's not just the behavioral health provider interacting with that patient, but you're getting some expert advice from the psychiatric consultant who's actively reviewing the caseload of patients. Next slide. People ask you about, how do you do this work? How do you get started? And all this I just said sounds really great, I'm sure. And okay, yes, we all want to get our patients better and see them improve. Working out how you actually do this and put this into practice is tough work. And we know that when we're working with practices all over the state on this work now. And it takes time, but people can do it, and they're doing it really well around the country. And it's about adapting these principles, again, to your setting to make it work. Go ahead to the next slide. I put this out here just because I think these are just some early lessons from our work around the state, but really thinking about, your stepped care approach to care. Where does collaborative care fit into everything else you're doing as a clinic or as a system or as a region in the Northstown region? We have found that thinking about organizational readiness and we have a checklist that I asked Lindsay to post, or I think she'll send a link to. So asking yourself questions around, are we ready to embark on this effort? Are we ready to hire? Have we thought about how we're going to finance this? Have we thought about, do we have other competing demands at our clinic right now? Are we transitioning to an EHR? Those kinds of things. So organizational readiness is really important. We're finding too that roles are emerging in this whole person care work where people are combining things. So maybe you hire a nurse and they're part of your collaborative care team, but they're also taking on managing a caseload of patients for opioid use disorder, medication-assisted treatment, or maybe there's a new navigator, care coordinator on your team, and how did they interact in this model of care? I think people still ask us around the financing and sustainability question. For primary care, there are options with psychotherapy codes and the collaborative care codes. For behavioral health agencies, I think as they're struggling to figure out how do I think about primary care now and physical health outcomes, the funding picture for that is still a little unclear. We're trying to work on that with the state. So these are just some kind of early learnings that we have from our ACH work. Go ahead to the next slide. So I'm going to go ahead and pass. I think, I've painted a big picture view of collaborative care and some of these principles, but to really get a feel for this work, you need to hear from a practice. And so I invited Dr. Chalmers, who's one of the founding members of the Skagit Pediatrics, to this, and she's just well known around the state in her work around pediatric behavioral health integration. She's been consulting with Skagit Pediatrics to help them start their program, at the same time helping efforts around the state, helping pediatric practices think about behavioral health integration. So she's going to tell you a little bit more about the journey with Skagit Pediatrics. So thank you.
Thanks, Lindsay. We're going to switch gears a bit here, and I'm going to describe some of the processes that one pediatric clinic has been going through in implementing behavioral health integration and specifically the collaborative care model. But before I go into those specifics of that journey, I wanted to give a little background as to why this is important, particularly in the pediatric age group. Next slide, please. This slide is based on a position statement put out jointly by the AIMS Center and the Washington Chapter American Academy of Pediatrics a couple years ago around the issue of behavioral integration in primary care pediatrics. And it shows some of the statistics regarding the incidence of behavioral disorders in childhood, how many of these are not recognized until adulthood. And you can see from these numbers, there's a very large gap in behavioral health service delivery for children and adolescents. And this has a significant impact on adult outcomes. At Skagit Pediatrics, one of the first things we did at looking to improve our behavioral health integration long before we had the ability to hire a provider was to set up improved systems of bidirectional communication with one of our community mental health centers. And in that process, we identified that only 10% of the patients we referred to that center actually ended up getting an intake appointment, and let alone getting established in care. Next slide. So one of the biggest changes in a day in the office for a primary care pediatrician in the last 20 years has been the number of behavioral health related visits that happen each day. And in addition to that, the number of times a behavioral health related concern comes up in the course of a non-behavioral health related visit. Hence the validating the need for whole person care in the primary care setting. Next slide. Just really quickly, the barriers to access to care are multifactorial. There is certainly a shortage of providers, at least in our community. There's limited Medicaid reimbursement so that private therapists are not enrolling in offering Medicaid care to Medicaid patients. But additionally, when we looked at why our referrals weren't happening, things that came up were a stigma that kept families from going to a mental health center, lack of transportation, inability for parents to take time off work, and a desire to have that care part of the care they received at their medical home. Next slide. So Sarah talked a little bit about the continuum of behavioral health integration, and I won't dwell on that too long here, but I think what we found in our experience with our clinic and other pediatric clinics that have been working on this in the Western Washington is that most people are developing kind of a meld of models that vary depending on location and patient population. Next slide. A little bit more about Skagit Pediatrics, just to put in perspective where we're coming from. We're a small single specialty practice. I actually retired from seeing patients in mid-2017, but have continued on in a management consulting role, and lately more in the area of developing our behavioral health integration project. We have the equivalent of 7 FTE providers, a mix of pediatricians and nurse practitioners and PAs. We offer extended hours with available same-day appointments and Saturday clinic. And in addition to traditional nursing staffing of 1 MA per provider seeing patients, we also have a full-time triage phone manager, referral coordinator, MA who functions as a care manager to follow up on daily ER and urgent care visits, and are working to develop a plan for a project manager position. We became patient-centered medical home certified in 2017. We always felt we were a medical home, but the process of going through that certification, although it was lengthy and expensive and time-consuming, was really valuable in that it validated that we were doing a lot of things well, but also gave us insight into some significant improvements that we could make, and a structure for documenting and planning that has really helped with the process of implementing the behavioral health integration project. And then along with that, around the same time, actually, we became a partner in the Pediatric Transforming Clinical Practice Initiative, which again helped us with planning and implementing various improvement projects. Next slide. Really quickly, we have a panel of a little over 9,000 children up to age 21, a little bit older for our kids with chronic illnesses. Our panel size is 50% Medicaid. Our visits are 58 to 60% Medicaid. And we struggle with the low Medicaid reimbursements, and in particularly in looking at sustainability for a behavioral health provider. Psychotherapy codes for Medicaid are pretty low, and there's no reimbursement for Medicaid, from Medicaid for care management services. And although there's hope that the collaborative care codes will improve sustainability, the jury is really, I think, still out on that. Next slide. Our implementation timeline actually goes way back to the yearning previously mentioned for having a social worker on our team to help us with the work that as pediatricians we're neither trained for or given time to do. But then in 2016, several things happened at once. I mentioned the PCMH and the involvement with Transforming Clinical Practice Initiative. And through that, we became aware of the AIM Center, became familiar with its robust website resources. In 2017, after we completed our PCMH certification, we basically transferred the team that was working on that project to a new team with the same members to create a behavioral health integration implementation team. And that team is consisted of myself, an additional physician champion, and 2 members of our administrative staff, a billing representative and a nursing representative. Next slide. In 2018, we enrolled as a North Sound ACH partner. We had been looking for funding support. We'd identified that there was a significant fiscal gap between what it would cost to hire a licensed clinical social worker and what we could get from billing. We weren't able to find adequate funds to support that gap, but through enrolling with North Sound ACH, we got both training support and the fiscal support to finally move forward. And one of the early learning opportunities through the North Sound ACH was the ability to join a cohort of pediatric clinics from Western Washington on a collaborative care model learning collaborative put on by the AIMS Center. This, along with a lot of literature searching and book reading, led us to the decision to hire a licensed clinical social worker in February of 19. Interestingly, we had impulsively put out a job posting for a social worker several years prior, well before we had any plans of how we would use that person. And we got several applications, but quickly realized we weren't ready, so closed the position. When we reposted in February, one of the people that had applied 3 years ago applied again and said, hey, you guys, I'm really interested. Besides, my child is a patient at your practice, and she was a perfect fit, and we hired her. Talking about at the same time, we've been talking with a local psychiatrist about his taking on the role of being a consultant along with the collaborative care model guidelines. And we were able to accomplish that contract with him in May of this year. So how have we set up our behavioral consultant at Skagit Pediatrics? Although this slide looks pretty neat and tidy, this has really been a study in PDSAs and continuous quality improvement at its best. And admittedly, sometimes just plain old trial and error. Just recently, we've looked at what our provider has been doing in the last 6 months and realized that we've very quickly fallen into the trap of having her see too many patients for psychotherapy. There's a high demand for this. Patients love staying at the clinic for their psychotherapy needs, and it is something we can bill for, but it wasn't the goal that we had in establishing this position. So we've had to step back and regroup again. We want our behavioral health consultant to be readily available for warm connections. We call them that rather than handoffs because it implies more of a team approach, and available for collaboration and consultation on care plans with primary care providers, care management support for her panel, even though much of this is currently not reimbursable time. So I failed to list, I'm sorry, you can see that psychotherapy is now sort of at the lower end of this slide, with one exception in that on the first week that our therapist was hired, she participated in training at the PAL program in Seattle for short intervention therapy for depression and disruptive behavior. This is an evidence-based intervention taught by psychologists at the PAL program at the U, at the University Psychiatry Department in Seattle, and they've developed a set of protocols that they're calling FAST-D for depression, FAST-B for behavior, and are working on one called FAST-A for anxiety. Next slide. Additional behavioral health consultant management roles include, of course, maintaining and managing the collaborative care model registry, care coordination with access to community resources, provider education. We've implemented a behavioral health consultant tip of the week at our bi-monthly provider team meetings. And sometimes this tip of the week has resulted in significant learnings and new PDSAs for our implementation planning. And also we hope to get her more involved in patient education through newsletter or info blogs on our website and social media sites. Next slide. The office and workspace workflow is significant. We have our behavioral health consultant working in the back with the PCPs and nursing staff as an integral member of the team. Warm connections occur preferably in the exam room after a brief introduction by the PCP. Scheduled psychotherapy appointments, however, are held in a designated therapy room with more appropriate physical setup. And we are really trying to limit these to just 3 to 4 a day. We do have our provider scheduled to be at the clinic one late evening a week, and those afternoon and evening appointments get picked up very quickly. For charting and phone care management, the behavioral health consultant has a desk in one of the group provider offices with 1 or 2 other PCPs to facilitate communication. And the provider also has a weekly huddle with members of the integration team and is available for 30 minutes prior to the first clinic appointments for any questions PCPs might have about their daily schedule. Next slide. The consultant charts in the EMR same as the PCP, using note templates that have been co-created with the provider and a PCP champion. And these notes are shared with the designated PCP as either an FYI or with specific care management questions and plan ideas. Patients have the opportunity to communicate with the behavioral health consultant via the portal, same as they do with their PCP. Tracking systems have been a bit of a challenge due to the time-consuming need for double entry. Our EMR is a pediatric-focused EMR. It's excellent in many ways, but it doesn't have a ready tracking system available. We have been piloting the AIM Center digital caseload tracker that Sarah showed you briefly. And this has been somewhat adapted for pediatrics with the addition of ADHD tracking tools. But it does require significant time for the behavioral health provider to maintain. At the same time, we've been working within our EMR to create reports that will allow the behavioral health consultant to track the entire scope of encounters, including those outside of the collaborative care model. We hope that once we get this figured out better, we will be able to engage our EMR provider in formalizing it so that it's a little more straightforward. Next slide. Billing and coding have been somewhat of a challenge, but we're definitely making progress, and that is largely, I believe, due to the fact that we have a superb and dedicated certified coder on our clinic staff. On her own, she took a class on behavioral health coding in the primary care office specifically for this purpose, and has put in countless hours pushing along the credentialing process, billing and rebilling and working with payer reps, basically to explain to them how they should be paying our claims. And we found a lot of this is new to them, and when the rules are politely pointed out, we have been paid. Credentialing took several months. One commercial insurer told us there was no need to credential our provider because they had plenty of resources available for us in the community, but They were unable to give us any names, and now, although we have to step through the hoop of a prior auth, our provider can see those clients, those patients. We started to bill psychotherapy codes by the second month. Our provider was here, and collaborative care codes by month 5. The latter does require extra attestation forms, which we learned had to be done not only for the behavioral health provider, but for each of our PCPs. Payments started coming in, but again required substantial phone time with payers by our billing staff. Issues around consent have also been a learning curve and led us at one point to learn that we also had been less than successful in explaining the collaborative care model concept to our providers, despite thinking we had done this quite well. And that has led to additional efforts to, and time, communicating between the implementation team and the providers. Next slide. Our participation in the AIMS Cohort Learning Collaborative has been an extremely valuable resource. The timing was perfect for our implementation process. It included a series of initial webinars, a day-long in-person session that was that allowed us to network with other clinics, meet other providers, both pediatricians and behavioral health consultants, who are doing the same work in somewhat different ways depending on their community and setting. And we've continued to share ideas since that session several months ago. In addition, we've had monthly dedicated calls for Skagit Pediatrics alone with one of the AIMS consultants that has allowed us to get feedback and has encouraged accountability on our part in moving forward. Next slide. Next steps. We've made significant progress, but we've got a lot of work ahead of us yet, and continue to be very appreciative of the support to schedule 5 days to improve our registry work and work on developing a report system within the EMR. We continue to attempt to engage providers in the concept of supporting within payer contracting, the concept of behavioral health integration outside of what is currently reimbursable. Assessment and outcome measurements is an area that we're working hard on. It's a bit more difficult to define these in pediatrics, but so far we're working on surveys of patient and provider satisfaction, reduction in the ER utilization for adolescent depression and suicidality, perhaps school attendance, both at preschool age for the kids with disruptive behavior and during the adolescent years, and ongoing monitoring of behavioral health referral completion rates. We have seen significant improvement in our referral rates despite an ongoing shortage of providers in the community. And actually on our provider's very first day, we were able to avoid an emergency room visit for a patient who showed up with her mother with acute suicidal ideation. And instead of having to send her to the ER, we were able to have our behavioral health consultants meet with her, do an assessment of acuity, develop a safety plan, and arrange for a psychotherapy appointment the following day. So that's all I have at this point. I think we have hopefully a little time for questions. And But before then, Sarah's going to talk a little bit more about AIM Center training strategies.
Great. Thanks so much, Dr. Chalmers. Wow, it's so impressive your journey around behavioral health integration, and to see how far you guys have come. A lot of really great tips and tricks. Lindsay wanted me to chat with everyone about kind of our training strategy and approach at the AIM Center and some resources that we have. So maybe go ahead to the next slide, Lindsay. Dr. Chalmers alluded to this. So we kind of divide our training program up into really, well, 3 parts, I would say. And Dr. Chalmers' clinic was part of what you call a pediatric learning collaborative with other pediatric practices in Western Washington this last year. And there were 5 clinics, and it's really great for groups of clinics to come together because they can learn from each other as well as from us at the AIM Center, our faculty and our trainers. But how we do it is we divide our training into 3 phases. So the first phase is what we call planning for integration. It's really around readiness. You know, who do you hire? What do you look for as you're thinking about a psychiatric consultant, behavioral health provider? Developing the workflows, the foundational workflows you're going to build your program off of around screening for behavioral health and primary care, around treatment, and what does that look like, getting your EHR set up with the appropriate templates, walking through how you're going to do a registry, what registry tool are you going to use. That all happens in the planning phase. Often that's delivered through a series of webinars or individual coaching calls and a mix of both we like to do at the AIM Center. So that's that first phase, the planning for integration phase. And that can take anywhere from, 3 to 6 months, I would say, and sometimes even longer depending on hiring for a practice. Then we bring everyone together for an all-day in-person training. That's what Skagit Pediatrics participated in, where we have clinician trainers who have done this work, are from the field, who train clinical teams around how do you then actually do collaborative care in clinical practice, from patient engagement to that initial assessment to that systematic case review. What are those key foundational skills to get you going and started and launching your collaborative care program? So we also often have a part for psychiatric providers as well as for PCP champions. That's the in-person clinician training. We follow it up with a lot of coaching support, because we know once we say, okay, here it is, here are all the things you need to do to get collaborative care going, there's a lot of additional support to really get measurement-based care embedded into practice, to think about how you're going to sustain your program, to figure out how you're going to use that registry so it becomes not just a data entry tool, but it's part of ongoing routine care. We try to think about, too, what are those additional clinical skills you might need. If you're working with more of an adult population, it might be some additional clinical training around problem-solving treatment. If you're working with more pediatric population, it might be more around how do you engage the families in this work, and how do you think about using CBT and some other psychotherapeutic approaches. And so that's that coaching support that happens through phone calls, individual calls, and sometimes webinars, case conference calls with our training team after you launch your care. So this is what how we typically train. Our training program looks like at the AIM Center. I think if you have an interest in being part of this kind of a training program, what I'd encourage you to do is to reach out to Lindsay, and she can provide details at the end of the webinar. We like to group practices by readiness, and sometimes also by population, like Skagit Pediatrics is part of a pediatric-focused training program, but sometimes we do it by rural or urban or readiness. It just depends. A couple other things happening at the AIM Center I want folks to be aware of. If there is a psychiatric provider in your practice or in the community that's interested in learning about this model, and there's a really great training program called the CommunityBased Integrated Care Fellowship that's available and accepting applications right now. The cost is free for Washington State providers. It's actually through funding from the Washington State Legislature. It does require quite a commitment, though, to be available for in-person meetings and some one-on-one mentoring and small group meetings. But I know there's been psychiatric providers in North Sound that have participated in it. And it's not just for psychiatrists, it's for nurse practitioners as well as physician assistants, physician assistants, sorry. Next slide. I want to open it up for questions. I know we have a lot of resources on our website. That's often where people start. There's a really great book that our director, Dr. Amaratsa, published around integrated care, creating effective mental and primary health care teams. We have office hours too every month where people around the country call in. I mean, we have 20, 30 people from around the country trying to implement at any time this work, and they'll call in and ask questions and get support from peers in those office hours, and those are free. We have one that's around implementation, one that's around registries, and one that's around financing and sustainability. So those are just some resources that we offer at the AIM Center. Go ahead to the next slide, I think. All right. Lindsay, do you want to open it up now?
Yeah. Hey, everyone. If you have any questions and would like to send those into the chat box, we'll try to address them in the next couple minutes here. If questions do come in that we can't get to, like I said, we'll send out a frequently asked questions page at the end along with this recording. We do have one question that came in, Sarah, and it was, if we want to partner with other organizations in the ACH, how can we do that with the AIMS Center or through the AIMS Center?
Yeah, so partnering with other organizations, I'm hoping, Lindsay, that ACH has opportunities for like different organizations to come together. We definitely work with partnerships. So we have both behavioral health, practices as well as primary care working on their collaborative care implementation that are part of our training program. The ACH has generally been the one to facilitate kind of those partnerships, I would say, because they know their region the best. So working with both the ACH and then ourselves to help provide the training for it, I guess.
Okay, yeah, great. And if partners do want to come together and convene on collaborative care and work with the AIMS Center, please feel free to reach out to me and I can help make that connection. We have another question coming in, Sarah. Can you say more about the balance of using case managers versus counselors, social workers in this model, and creating a registry that allows shared information across providers or other services that the patient interacts with?
Right. Yeah, so so let me start with, counselors, social workers, so that's that behavioral health provider role who really is the one carrying the caseload of patients and providing brief interventions, approaches. And then the consultant role is a psychiatric provider. It doesn't have to be a psychiatrist, it could be a psych nurse practitioner. Case managers, so I think sometimes case managers might be able to help support the team. They might help with some general care coordination duties, connecting patients on the caseload to social supports and resources. They might help with some of the data pieces. Sometimes clinics use an MA or a case manager to help with some of the data pieces. We don't encourage it, but it sometimes has to happen. They might help with some home visits, those kinds of things in the field. So those are ways that you can involve both a case manager on the team. The key role, though, is to have a behavioral health provider that's usually a social worker or kind of counselor that's part of that primary care team.
Great. Thank you, Sarah. We have one more that came in, and that is, does the AIMS training include information on how to create a registry that allows shared information across providers or other services that the patient interacts with?
Yeah, that's a good question. So the registry we talked about is a web-based application, so that providers from different practices, anyone can log in. It doesn't live on someone's own network. But as far as like EHRs, interoperability between EHRs, that kind of thing, that's definitely not our expertise. We have some EHR and caseload tracker pilots going on around the country that we're really excited about. Not enough to tell you that we're like there and figuring it out, but we are piloting with a couple EHR vendors and our registry tools on how to make them seamless. But we're not there yet, so it does at this point require dual entry into the cloud-based AIMS caseload tracker as well as into your EHR. We've tried to, over time, make our caseload tracker tool as streamlined as possible, so it's just like entering key data points and contact dates without and all your note information lives in your EHR.
Great, thank you so much, Sarah. And like I said, we'll include these questions and answers and send those out with this recording. Just a heads up to everyone, we have some upcoming webinars and we'll be sending out invites and marketing around that. So please keep an eye out for that. I just want to thank you, Dr. Chalmers and Sarah, for your time today and giving us this great information. And again, if there's any questions or connections that need to be made, please reach out to either myself or our team at northsoundach.org email.